And now I will give the floor to Dianne Gove. She is Information Officer of Alzheimer Europe, and actually she is one of my PhD students, so I'm happy to introduce her.
Thank you, Mira. So, good afternoon, ladies and gentlemen. In the next 20 minutes, I'm going to provide you with a few background details about Alzheimer Europe's work on ethics and about the working group, and then show you a few examples of our recommendations on each of the topics covered. And this is more or less taken directly from our recent publication on the ethics of dementia research. So Alzheimer Europe started its work on ethical issues in 2009 when it received funding from the German Ministry of Health to set up a European Dementia Ethics Network, which would bring together experts in ethics from across Europe and involved setting up working groups to debate various ethical issues and develop recommendations. The work on the ethics of dementia was the second topic to be addressed, and as you can see, we are now working on ethical issues linked to the deprivation of freedom. In this slide, you can see the names of the experts in the working group on the ethics of dementia research. In addition to their experience in dementia research, these experts were from a range of professional backgrounds such as bioethics, philosophy, medicine, psychiatry, law, neurology, and end-of-life care. There was also one person with dementia, 2 carers, and 4 people from Alzheimer associations. Our recommendations on ethics were intended to cover all kinds of research, and we based them on a very broad definition of research. Actually, I'm just going to skip this definition at the moment because we're a bit short of time. Most of our recommendations apply to both medical and social science research, and on this slide you can see some of the main domains included under those general categories. We nevertheless, in our report, had a separate section on medical research, as some of the issues were in fact different. On the other hand, we were keen to promote social science research into dementia-related issues, as its importance, we felt, is sometimes overlooked. Our report and the recommendations are divided into the sections that you can see on this slide. In the remainder of this presentation, I will take each section of the report and highlight a few key recommendations. And this is just a small part of the full set, which can be consulted on Alzheimer Europe's website. And you can see the address at the bottom of the slide here. So the first section, involving people with dementia. It was agreed that people with dementia have an equal right to participate in research and also to take risks, just like other members of society. However, people with dementia should also be consulted during the design phase of research projects, in the definition of meaningful outcome measures, and, if appropriate, concerning the initial choice of topic. There is a need to ensure that older people are involved in the clinical trial of drugs targeted for future use by people with dementia. Drugs must be tested on groups with the same characteristics as those who will use them, and this is often not the case. Drugs to be used by older people are often tested on somewhat younger populations, even within the category older person. And this means on people under the age of 75 or 80. And there are several possible reasons for this, such as concerns about comorbidities, adherence, polypharmacy, and the absorption of the drug in the body. However, these issues do not apply to all older people and are not limited to older people. On the other hand, many people with those characteristics will be taking those drugs which were considered safe on the basis of tests carried out on very dissimilar people. In addition to including older people in research, attempts should be made to include people with dementia of all ages and from ethnic minority or other racialized groups, and people with dementia with visual, auditory, and intellectual impairments, or with less common forms of dementia in research. And this is linked to the principle of justice, of having the same opportunity to take risks and to benefit from research as other groups of people. And the term racialized is used here to refer to various subgroups of the population which are often neglected. And their involvement should not be limited to their perceived ethnic or racialized characteristics, or to a narrow range of topics typically associated with other people in their subgroup. They are likely to have more similarities than differences with other people with dementia and are not simply the exception to the norm. The group agreed that capacity in the case of dementia is linked to a particular task or decision that needs to be made and cannot be assessed globally on a once-and-for-all basis. People with dementia at various stages of the condition may have the capacity to do some things and not others. We therefore recommended that a person should be deemed capable of consent unless proven otherwise. The knowledge or belief that a person has dementia should be considered as reasonable grounds for doubt concerning his or her capacity to consent to research and to justify the assessment of his or her capacity. A diagnosis of dementia, or the belief or presumption that a person has dementia, should never be considered as sufficient proof that a person lacks the capacity to consent to research. And we recommended that attempts should be made to ensure that researchers have access to relevant and appropriate tools for the assessment of the capacity to consent to research, as well as to training in how to use them. We felt that whilst direct benefit to the person with dementia should not be a condition for participation, every attempt should be made to ensure that participants in dementia research are well treated and that as far as possible it is a pleasant experience. We recommended that researchers should envisage the possibility of participants experiencing emotional or psychological harm and ensure that any person who is exposed to their research materials or data collection processes knows whom to contact for support. Researchers should, through their own behaviour and attitudes, strive to promote and protect the dignity of people with dementia, even in cases where it seems that the latter are not concerned or lack awareness or insight. And researchers should try to meet people with dementia in a genuine human exchange, even in the absence of verbal communication. The use of deception, particularly with participants who have dementia, should be avoided and only used in exceptional circumstances. And even then, we felt that participants should have the right, once debriefed, to request that any data collected from them be excluded from the study. The issue of risk, burden, benefit and paternalism can perhaps be summed up by the aim to strive for the right balance between protection and the promotion of autonomy. We recommended that it should be recognised that zero risk may be a worthy aim in the development of medication, but that it is not necessarily realistic or even desirable in all other aspects of people's lives. That paternalistic practices and attitudes should be avoided, that people with dementia should not be treated like children or stereotyped as helpless, and also that they should not be labelled in a blanket fashion as vulnerable. With regard to benefit, we did not consider it appropriate to place a condition on participating in research that the study be of direct benefit to the person with dementia, as people have many different reasons for taking part in research, and benefit is not always one of them. We felt that the typical definition of benefit is too medically orientated and does not take into account the kinds of benefits which are possible and important to people with dementia taking part in research. Great care and sensitivity should be taken in the communication of the results of epidemiological research in order to reduce the likelihood of fear, stress and blame and the stigmatization of those groups most affected by the findings. The attribution of responsibility and blame has been found to increase the likelihood of a particular attribute becoming a stigma, and so it is therefore important how findings are presented and interpreted. Research protocols should address potential risks and possible solutions linked to the continuity of the study over a sufficiently lengthy period of time, and to future challenges to the validity of the results of each study. It would be unethical to allow people with dementia to invest so much of their time and energy, or without dementia, time and energy, in a study which could not be effectively conducted in the long run. The working group recognised that genetic data does differ in some ways from other types of medical or personal information and is sensitive, but also of the risk of a paternalistic approach to genetic research, which may deny the public the tremendous benefits which could result from such research. So our emphasis was therefore on ensuring that potential participants understand what they are agreeing to, that the wider implications of knowing are considered, and that measures are in place to protect participants from the further use of their data or from the inappropriate use of findings. Very little is known about the genetic literacy of older adults. Researchers should therefore ensure that participants fully understand explanations about genetics and genetic research, starting with the terms that they use. And the insurance industry should be dissuaded from the inappropriate use of information about the genetics of dementia until cause and effect relationships have been scientifically established. And at the same time, research findings should also be used to identify reduced risk. And Alzheimer Europe recently expressed its views in the Council of Europe's consultation on productivity, testing and insurance, that research into protective factors also be taken into consideration when calculating risk. The working group discussed at length the issue of the use of placebo arms in clinical trials in the light of arguments that proven effective drugs exist for the symptomatic treatment, but we concluded that depending on the type of drugs being developed, for example, a new compound or an existing compound, that the necessity and scale for a placebo arm should be different. We recommended that researchers should consider including a placebo arm in clinical trials when there are compelling sound methodological reasons for doing so, to ensure that patients are always aware that the aim of a randomized controlled trial is to test a hypothesis and produce generalizable knowledge leading to the development of a medical drug or procedure, and to ensure that potential participants understand that they may be allocated to a placebo group. And with regard to dementia research in general, the group emphasized the need to ensure that participants understand the fundamental difference between research and treatment, but especially in situations where it is being proposed or carried out in a medical setting. The working group felt that research into end-of-life care should be promoted. In particular, research should be carried out to develop more precise indicators of end-of-life and appropriate end-of-life care and treatment. We recommended that stereotypes about people who are dying with or from dementia, such as linked to well-being, quality of life and capacity, be challenged. It should not be presumed that people with dementia would not want to participate in end-of-life research, and that researchers should approach people who are dying with or from dementia about research with great sensitivity, paying attention to possible signs that they do not want to discuss this issue, or that they are either not aware of or in denial about their prognosis. And finally, that the issue of recording dementia as a cause of death on death certificates should be addressed. So I'll just cut a few slides because we're short of time. If anybody would like to read the full report, it can be viewed online on our website, and it's also available in printed form. So thank you for your attention.